Welcome to Navicent Knows Health. I'm Cindy Busby, and I'm here today with Dr. David Lovejoy. He's board certified in gynecology and fellowship trained in urogynecology, and today we're going to talk about his practice here in Central Georgia. Dr. Lovejoy, thanks for being with me.
No problem. Well, thank you for having me. Thank you for having me.
We wanted to tell our audience today a little bit about what is urogynecology, and if you could define the pelvic floor for the viewers.
Okay, both good questions. I know it's a little nebulous when we say urogynecology. So it's essentially urology for women. You could kind of consider us the plumbers, I guess, of the pelvic floor, so to say, and that gives a leeway into what is the pelvic floor. So in your pelvis, the biggest kind of organ systems are your genitourinary tract, which is the bladder, it is the vagina, uterus, cervix, and then also the GI tract. So think of colon, rectum, etc. And so we treat any disorder or dysfunction there. That most likely is going to be pelvic organ prolapse, which is herniation of either the bladder, the rectum, cervix, uterus, or possibly the vagina, completely out or into the vagina. Can result in a lot of pain, pressure, discomfort. We treat incontinence, that's both fecal incontinence and urinary incontinence. We treat overactive bladder, that's urinary urgency, frequency, or nocturia, which is a term that's used to describe just you're getting up frequently over the course of an evening when you're asleep, waking up from sleep to go to use the restroom. We treat recurrent urinary tract infections. And that's kind of I would say those are the big ones that we kind of manage, but that doesn't completely cover everything.
When you talk about prolapse, so we use that term, or herniation, that's actually when your pelvic floor, your muscles can be so weak that your organs begin to fall.
Correct.
Basically through them. So is that what you see when people are older, or maybe they have an injury? So how does herniation happen, or this dropping of the organs?
Well, I should probably say, I think a good point to take home is that none of these disorders are normal. Some people come in and say, oh, this is just a normal part of aging, I'm just going to deal with it. And that's not the case. Now, they're more frequent as you get older. And what we've kind of come to know is that there's not one catastrophic event that usually results in these disorders. Most of the time, it's kind of over a woman's lifetime, lifespan, there's multiple tics that eventually lead to these. Maybe childbirth, maybe weight gain or obesity. If you've had an operative vaginal delivery or multiple children. All of these things can play a role, as does age, and we just tend to see the, I guess, the overall outcome when you get older and into your postmenopausal years. But sometimes women present much earlier. Some women can be genetically predisposed for this, and we don't know why or what causes it. So.
When a woman recognizes that she might have some of these conditions, so frequent urination, incontinence, or not being able to control when she goes to the bathroom, and what is the path to getting to your office? What's most common?
I would say most common, a lot of these women will go either to their primary care physician or maybe their GYN physician, and hopefully either they bring these symptoms up or hopefully the physician asks them about them. But again, like I said, this isn't something that we consider normal, but some women do. And so if the primary physician's not asking the question and the woman's not bringing it to their attention, we sometimes lose a lot of patients that could definitely benefit from either conservative management up to less conservative options such as surgery.
Do you think there's more of a discussion around women's uro-GYN health, so incontinence, maybe not so much prolapse, but around incontinence now nationally, so that women are more comfortable with coming forward?
I'd say it's starting to move in that direction. I think there's more advertising by some of the drug companies that kind of direct that, and then that kind of puts the disorder on the radar of the patient. And so then they start asking more questions. Otherwise, you can always find it surprising when I tell someone what I do. You know, a lot of my peers outside of medicine kind of have to ask a lot of questions. They're not sure what prolapse is. They don't really understand incontinence yet, but some of them all of a sudden will say, oh, well, my mother has that. And then once you find one person, it's just kind of, it just balloons the number of patients that are actually dealing with these symptoms, and some of which have never sought intervention before.
When you talk about conservative So the idea that a patient could come and do something that isn't invasive or doesn't involve surgery. What's a visit like if a woman presents at your office or comes to your office and has one of these concerns?
So the first thing I always ask a patient that comes are, what are your goals from this disorder with whatever it is, the symptoms that you're experiencing? Now, I think that's important to find out, because some women come to our office and they absolutely, no matter what I tell them, do not want anything but surgery. They want the problem fixed and they want to get from A to D as soon as possible. Other women have no idea what the options are in general. They just want to solve the problem. And so I always like to give my patients kind of a full range of options. I think conservative management, if it can solve the problem, is one of the best options, because you can always take another step up the ladder. But it's hard to move backwards when you choose to kind of overlook some of the more conservative options. And anything that is low risk, high reward is definitely something we celebrate in medicine. So,
When you talk about fecal incontinence, that's also another discussion that people aren't really having openly.
Correct.
We've talked to other practitioners who talk about post-radiation therapy problems with that. You treat exclusively women for fecal incontinence, and maybe you can describe what fecal incontinence is for the viewers so they know.
Okay, so fecal incontinence, you can kind of lump it together with, some will call it flatal incontinence, or involuntary loss of gas, but also the involuntary loss of stool. And there's a lot of overlap here between what we do and what colorectal does, and I work closely with the physicians here at Navicent. Sometimes patients are more appropriate in their clinic and some are more appropriate in mine, just depending on what the source of the problem or the complexity of their symptoms are. But we often, again, with incontinence, fecal incontinence specifically, it's a very much a conservative path to start, starting kind of with dietary modifications and then fiber supplementation, medications, and then we kind of move again up that ladder, and if it is appropriate for some patients, surgical intervention may be beneficial.
So if a patient watching today identifies any of these issues, they can either come directly to you or come through primary care. Can they self-refer to your office?
They can definitely self-refer to our office, yes.
Okay, well, thank you so much for telling us so much about your
Well, no
practice,
problem.
and it's nice to meet you, and welcome to Macon.
Well, thank you. I appreciate it. Thanks for having me again.
Thank you so much.
I really
Thank
appreciate
you.
it.
If you'd like to know more about Dr. Lovejoy's practice, you can visit us at navicenthealth.org.